Okay, hello everyone. We're at the top of the hour, 8 a.m. Pacific. So we'll go ahead and get started. I'll just start with a brief introduction. So my name is Ben Adam. I'm a pathologist at the University of Alberta in Edmonton, Canada. And on behalf of the Renal Pathology Society, it's my pleasure to welcome you to another edition of this collaborative seminar series between the RPS and GlomCon. Focused on nephropathology and the opportunity to chat with some of the experts in the field with on some of the topics that are emerging and controversial in our area. And today, it's my great pleasure to introduce our speaker, Professor Parmjeet Randhawa.
Yeah, thank you, Adam. It's a real pleasure and honor to be a speaker on this series, which has been on my Sunday morning calendar ever since I discovered this gem of an educational tool about a year ago. I try never to skip it, although there are times I have to do multitasking, such as doing it at the same time as tying my turban before going to a social event. All right, so I don't have any relevant disclosures. And here's an outline of my talk. This is a transplant kidney task. And it's the glomerulus and also the nephron distal to it. I think I like the idea that the GlomCon takes a liberal view of what a glomerulus is. And I will begin with strengths and limitations of mRNA-based diagnostics and its applications to evaluation of kidney graft dysfunction. There's a lot of lingo I'll be using since not all of you are transplanters. Let me say ABMR means antibody-mediated rejection. BL is borderline changes, suspicious for acute rejection. TCMR is acute T-cell mediated rejection. And CA-TCMR is chronic active TCMR. The V lesion is intimal arteritis. And the ATI is acute tubular injury. So there are a lot of technical approaches to mRNA diagnostics. There's multiplex RT-PCR, there's RNA-seq, there's nanostring. Then there's DNA microarray technology, especially the MMDX system, the molecular microscope invented by Dr. Halloran. Most of the literature in the area is actually, MMDX based. So you'll find me quoting a lot of data from those investigators, and I will use that data primarily for illustrative purposes. So let me put this idea of molecular diagnostics in perspective. As we know, reaching a clinical diagnosis is a systematic process. We have to take the history, the physical exam, the labs, radiology. And similarly, reaching a pathologic diagnosis must also be a hierarchical process. A gross evaluation must be a key first step. If we do not slice an organ thinly, do not visualize an infarct, and do not make sure that it's sampled, well, no histologic or molecular diagnosis is going to give you the correct diagnosis. So the light microscopy extends our gross vision to about a micron. Electron microscopy extends it to about 1 nanometers. And the lower down you go, the more critical the sampling becomes as to what you're looking at and to put it in context. Immunohistochemistry allows identification of specific proteins. And then transcriptomics adds the very important spectrum of molecular features, which, however, must always be correlated with other features. So I put transcriptomics at the bottom because that's where it belongs. It has to be correlated with everything else that goes beyond it. And I have to stress there are some indispensable strengths of histologic examination, which we tend to forget. It provides structural context to the molecular findings. It allows the gross topographic regions affected to be specified. For example, in the capsule, we might attribute the inflammation to surgery. Cortex would be rejection. Medulla might be pyelonephritis. Then histology localizes the disease to specific microcompartments. In the glomeruli, we can make diagnosis of FSGS. In the tubules, BKV nephropathy, interstitium, drug-induced nephritis, and then a whole lot of vasculitic disorders when we examine the vessels. The cell type affected is identified, which is important. For example, you can say proximal tubular vascularization is important for diagnosing cyclosporin or tacrolimus toxicity.